Carl, if that's good. Great. Good afternoon, everyone, or for those of you who are on the East Coast, I guess it's good afternoon. My name is Katie Fitch, and I am a nurse practitioner. I've been the project manager for the REPRIEVE trial since its inception. And I'm here today with Marissa Diggs, who's a study coordinator working on the REPRIEVE trial. We both work at the Clinical Coordinating Center at Massachusetts General Hospital in Boston, Massachusetts. We're so excited to be holding this community forum for people who were participants of REPRIEVE or anyone who's interested in the findings from the study. And we're really lucky to have Dr. Carl Fichtenbaum be presenting the results today during this community forum. Dr. Fichtenbaum was the vice chair of the REPRIEVE protocol and chair of the REPRIEVE site selection, performance, and closeout committee. And Dr. Fichtenbaum is a professor of clinical medicine and associate chairman at the Department of Medicine for Translational Research at the University of Cincinnati College of Medicine. Dr. Fichtenbaum's research has focused on the clinical investigation of HIV infection, mainly dyslipidemia or high cholesterol and cardiovascular disease in people with HIV. So I'm going to pass it on to Dr. Fichtenbaum.
Well, thank you very much for the kind introduction. I'm really excited to present to all of you today. I'm sorry it can't be in person, but that would probably be hard since we probably have people all over the place, including outside of the United States. But we're really happy that you came. I think one of the most exciting things about a study like this is it's really a partnership between the scientific community and the general community, because we try to solve problems that face human beings. And when we form a really good partnership, we're able to come up with ideas that may eventually have a meaningful result for people. So before I start anything, I really want to thank all those people who were kind enough to participate in the REPRIEVE trial. Really, the participants are the true heroes of and heroines of the study, because what you did was sacrifice and gave of yourself for others, and so that we could really learn how to answer a very important question. Now, many of you may or may not be aware, but we're going to talk a lot about heart disease, or what we call cardiovascular disease. And so that's really important because many of us know friends, family, neighbors, acquaintances who've had heart attacks or strokes. And that's what really heart disease or cardiovascular disease is all about. And when we think about the lives of human beings, we want them to be long, fruitful, quality-filled, and free of health problems like heart disease. So that's what we were all about when we got together as a group back in 2013 and designed this study and partnered with community members to make sure it really was addressing an important question. And we designed it in a way that it would fit the lives of people. So feel free to throw questions in the chat, and then we'll make sure we leave time to answer as many questions as we can. All right. So why REPRIEVE? Why did we need to think of this study? What's the reason for even doing this study? Well, what's heart disease, or what we call cardiovascular disease? Well, this is a disease of the blood vessels. Some people know it as hardening of the arteries, or atherosclerosis. And what it is basically is that your heart pumps blood all around your body through a very intricate and very amazing system. At the same time, your heart itself is a big muscle, and it needs to be supplied with blood. And there are specific blood vessels that supply or feed or nourish that, much like you watering your lawn or taking a drink of water yourself. And so those heart vessels can get blocked. They can get stopped up, like the plumbing in your house gets stopped up or your sink gets stopped up. no water gets through. And in the same way, if those vessels get stopped up and blocked up, no blood can get through. And if no blood gets through, then we can't nourish the cells. We can't take away waste products from cells. And what happens is those heart muscle cells die. The very same thing can happen in your brain. And while some of you may question whether politicians have brains, most of us have brains and we need them. And so we don't want a stroke to happen, or what a stroke is when the blood vessels are blocked up and we're not getting the kind of blood supply we need to the brain. So this process builds up when we build up deposits that we call plaques. So I don't know if anybody's ever, removed the stuff from you removed your sink drain cover or something and looked in the pipes, but you see all that gunk there. Well, some kind of gunk gets in our arteries too, from all the different things we eat, and also from all of the problems that we might have because of our specific genetic makeup. And those arteries narrow when that plaque gets bigger. And then there's a sudden event that can occur where a blood clot might form and all the flow is stopped. And that's that clutching chest pain that people get when they say they have a heart attack, or when somebody suddenly can't speak, or they lose function in one of their arms like a stroke. So these are the reasons why we were interested in the REPRIEVE trial and the background behind this. So for people who have HIV, their risk is actually increased. It's increased by 50 to 100% when you compare people to people who don't have HIV infection, but otherwise seem pretty similar with other characteristics. Now, some of this happens because we have other problems that we know about. High blood pressure, or the silent killer, people talk about that. High cholesterol or high lipids or fats in the blood can also lead to plaques. And of course, blood sugar. If you have diabetes, so your blood sugar is too high, that can lead to buildup of plaques. And then smoking, we've known about for many years, is associated with a higher risk of heart disease or strokes and heart attacks. But some of this is also driven by HIV itself. So HIV is an infection that we have yet to cure. And when you have HIV, there is sort of this ongoing stimulus in your body that's irritating you, kind of like somebody nagging you in your ear all the time, 24/7, 365. And we call that inflammation or irritation or immune activation. And that plays a special role in helping plaques to build up in people who have HIV. So all of these things can contribute to this. Even when you're doing a very good job of controlling your HIV, it doesn't really matter if you're controlling it perfectly. This level of irritation or inflammation, it's still that person talking in your ear 24/7, 365. So if we look at this nice cartoon, which shows a picture of blood vessels, I don't know if my pointer shows up or not, but you can see this cartoon where we have a nice open blood vessel all the way on the left side. And then as you move to the right of your screen, you can see that there are cells that build up, and some of those cells are immune cells. These are cells where you build up these plaque because these immune cells are causing some further irritation, and it leads to the plaques building up. But it also makes them a little different. Whereas some might be hard like a rock with a bunch of calcium in them, these tend to be softer, more pliable. They tend to bust open a little bit more. So even people who seem like they're pretty healthy with HIV may have some buildup of this plaque and not even realize it. And much of this is because of this inflammation. And we like to think of this plaque as a little bit more vulnerable to break open or bust open. And when it does that, it often leads to that clot and blocking off that blood vessel. And we've been able to measure this in a number of different studies. So how can heart disease or cardiovascular disease be prevented in people with HIV? Well, it's very important that people take HIV treatment known as antiretroviral therapy, or the cocktail, or one pill once a day, or some people take shots now too as well. We know that if you have HIV and it's not taken care of, that will lead to more problems with your heart. And of course, people get sick from the HIV. So it's very important to take your medication, because that helps to decrease the inflammation from HIV itself. And if you're not smoking cigarettes, that's great, because that reduces your risk for heart problems. If we can manage your cholesterol and your blood pressure and your blood sugar in a good range, and of course, if you exercise and eat well, these are healthy things. But are these strategies enough to prevent heart attacks and strokes? That's the question. So we've known for years that besides an apple a day to keep the doctor away, there are pills called statins, and we're wondering, could these possibly work for people who have HIV? They seem to work for other people. So what's a statin? Well, a statin is a particular medication that is used to lower cholesterol. It lowers a specific kind of cholesterol that we call LDL, sometimes known as your bad cholesterol. This is a kind of cholesterol that when it builds up, it causes more of those plaques or hardening of the arteries. So statins reduce that, but statins also do other things besides that. They're anti-inflammatory. They stop blood clots from occurring, what we call antithrombotic. They affect the immune system. They cause certain cells to not be as angry. They improve the health of blood vessels, and they often stabilize those plaques so they're not so squishy and more likely to rupture. So statins can provide a way through many different methods to try and lower the chances of heart disease problems or cardiovascular events. But do they prevent events like heart attacks and strokes? That's a key question. So in people who have HIV, we know that statins will lower LDL cholesterol. There are a number of studies that have shown they work, just like they work in people without HIV. We have also had several studies which show they decrease inflammation and that irritation that's occurring. So it's kind of like getting an earbud or those sound canceling headphones. And so that 24/7 voice is not in your ear all the time. We also know that statins will reduce fatty plaque and heart arteries. We've seen this in several studies where we've looked, if somebody takes a statin, can we actually reduce that buildup of fats in the blood, in those blood vessels? So before the REPRIEVE trial, we didn't really know for sure that statins would decrease heart attacks and strokes in people with HIV, particularly if they were not necessarily the kind of people that we would normally give a statin to. Now, what do I mean by that? Well, we have certain guidelines that doctors and practitioners tend to follow, which tell us that if somebody is at really a certain level of risk for heart attack or stroke, we should probably give them a statin. But if they're below that level, then we don't always say that they need a statin. Well, in our study here, we were really looking at people that were not only above, but people really below that level to try and see if a statin would help to prevent it. So with this in mind, we thought that this was a reasonable thing for us to test. A number of us came together in 2013 and developed this idea. And again, we partnered with the community to get their input as well. And we developed what is called the REPRIEVE trial. So and what REPRIEVE really stands for is a randomized trial to prevent vascular events in HIV. And don't try to make all the letters somehow match in some way because you'll drive yourself crazy. But it works in there. We've got the R's and the E's and the P's and the R's, I, E, V's. So it all works eventually. Anyway, so this is a randomized, which means like a flip of the coin. We're randomizing people. When you walked into the study, we flipped the coin. Half the people got the statin, half the people got placebo. And the statin we used in our study was called pitavastatin calcium, or some may know it as Livalo, as it's prescribed. So this study was really designed to address this unmet need. It's really the first multinational or international study that was randomized as a clinical trial. And it really is testing this strategy. Can we prevent heart disease or cardiovascular disease in people with HIV? So the primary goals of this study were to determine if this medication, pitavastatin, is effective in reducing cardiovascular disease, and then just as important, to determine is it safe. Because I'm sure if you're like anybody else and you've been in the community, you know there's a lot of talk about statins. You can go ask your neighbor. Your neighbor will probably have 7 opinions about statins, and some of which will be correct, some of which maybe not so much. But there's a lot out there, so we wanted to know, is it safe as well? So one of the things we did was figure out who are we going to invite to this study. And we want to invite those people who are going to benefit the most from this. So we took people who were ages 40 to 75. And they had to have a few specific characteristics. The first one that we looked at was something called your risk score. We tend to call this, we abbreviate it the ASCVD risk score, but what this is a calculation. It's an estimate. If I talk to somebody who's my patient and I say, what are the chances in the next 10 years you're going to have a heart attack or a stroke? We have this calculation to look at. And some people have a lower level, like their score is maybe only a 2% chance. And some people have a 20% chance. Now, of course, we'd like everybody to have a 0% chance, but the reality is that we're somewhere along that range, usually between, 1 to 20%. And it gets higher depending on if you're older. If you tend to be a man, if you're born a man at birth, men tend to have more heart attacks. If you smoke, you have a higher chance, or some of these other problems like high blood pressure. So you had to have HIV to be in this study, of course. That's very important. And you had to be taking your HIV treatment because we really wanted to look at this question in people who we thought were doing very well from the HIV standpoint, and we're really trying to prevent heart disease otherwise. And we enrolled people who had a low to moderate risk score. So this risk score I talked about. So we didn't want to enroll people who we already know would need a statin. We don't really want to study that question so much. So we were looking to enroll people where we wouldn't normally always give them a statin or recommend that. The statin we chose, as I mentioned in the study, was pitavastatin, and it was given at a dose of 4 milligrams, or there was a matching placebo. So as a doctor on the study or a researcher, I didn't know what my study participants were taking. They didn't know what we were taking. It was called a randomized double-blind study. And here's how we defined all the groups, and this is what we call our schema. So we took all these people at low or moderate risk, and we enrolled 7,769. Half of them got that dummy placebo. Half of them got pitavastatin. The researchers didn't know, and the participants didn't know. And what we were looking for was Would somebody get a heart attack? Would they have a stroke? Would they die from heart disease? Would they somehow have some other event like they needed to have a stent or bypass surgery to open up a blocked blood vessel, something like that, or even disease of the arteries of your legs or things where it causes a block there. We looked at all of these things combined and in an individual way, and we also looked for safety, particularly muscle aches or muscle problems, which are known to happen with statins, and diabetes, which is known to be associated with the use of statins. And then we looked at a whole bunch of other things, inflammation and what might work or not work if you take a statin. So what we were really looking at were cardiovascular events. We call this MACE events in the scientific technical terms, which are major adverse cardiovascular events. This is like a heart attack or a myocardial infarction or dying suddenly from a heart attack, which is what probably happened to my grandfather, you know, sitting at the kitchen table with my dad. Even before I was born, he died suddenly. People who are hospitalized because they had chest pain due to blood vessels being blocked off in their heart, known as angina or angina, a stroke where blood flow is blocked to your brain tissue, or what we call a TIA or transient ischemic attack. That's when you have those symptoms, but they only last for a short time and they're gone within a day. You know, somebody can't speak for a day or something like that, but then they're all better. And then also I mentioned this arteries in your legs. Some people can walk a short distance. Some of my patients have this, and they get a lot of pain in their legs because the arteries are not feeding the muscles and tissues in their legs and blood flow is reduced. Or you needed to have a treatment known as a stent or bypass surgery to open up blood vessels and feed your heart again. So we did this study all over the world. It was actually 5 continents. These are all the hearts all over the place. And it was 12 countries. We started enrolling people in March of 2015. As an aside, I had a little, friendly wager hoping that I could enroll the very first person on this study at my site, but a friend and colleague of mine in Alabama actually enrolled the very first participant. And we stopped enrolling people in March of 2019, and the study was actually stopped after an average of following people for a little more than 5 years by the Data Safety Monitoring Board. So what did our population look like? This is a little bit of a complicated slide, but let me take you through the most important points. The average age of people who enrolled in our study was about 50 years of age. And 2/3 of them were men at birth. 1/3 of them were women at birth. And this is very important because this is one of the largest studies to enroll women with HIV anywhere across the world, particularly a randomized treatment study. And there were, almost 2,500 women worldwide in this study. We also looked at whether individuals identified as cisgender or transgender. And then we looked at the different ethnicities and races of the population. And you should note that this study was a minority study done in white people. It was majority done in non-white individuals, reflective of the world's population. I think that's very important because it's much easier to really understand and apply the results when the study sort of looks like the world. So there you see 50 was the age, 31% women, and that the study was largely made up of non-white participants. Now, if we look at that score, about what I mentioned of what the rating was, the average cardiac risk score was about 4.5%. When it gets to be about 7.5%, that's when doctors start really talking to people about should you be taking a statin? So you could see that our number was below this. The LDL cholesterol, that bad cholesterol, this was an average of about 108, which is pretty mild. That's not very high. The CD4 count was very good in most patients. This is a marker of how well controlled your HIV is, how strong your immune system. Anything above 500 is terrific, and many of our patients were. And most of the people were undetectable, 88% of them. And those few people who were detectable were very low levels, mostly below what we would call a problem. So what did we learn from this study? What's the big result? And this is one of those complicated science slides, so let me take you through it because you can understand it. We follow people for an average of 5 years taking this statin called pitavastatin. And what we found was the big message that it reduced the risk of heart events by 35% compared to placebo. So if you look at this curve in purple, are the individuals who are taking pitavastatin. In this sort of more greenish aqua color were the people taking placebo. And after about a year, you could see the curve split. And there's a difference that more people in the placebo group are developing these heart problems compared to those in the pitavastatin group. And this is what we consider an important difference. So people might say, well, a 35% difference, is that really important? In the science world, that's a very big difference, a very big difference. And you can actually see the differences here, where it's about 2.7% of people in the pitavastatin group absolutely got a cardiac event compared to 4.4% of those on the placebo group. So if we look at this even further, we can see that the LDL cholesterol really decreased in the pitavastatin group. So here it was the average LDL cholesterol, and here it was at month 72, which is very reassuring that people were taking the pills. So sometimes people go on studies, they don't always take their pills, but we actually lowered cholesterol, and it didn't lower very much in the group that was getting placebo. So there was a difference between these groups. That's a very strong measure to show that people were actually taking their treatment. Now, was it safe? Well, here's the good news. Overall, there was a pretty equal safety in both groups. There was no difference. So when you look at serious events or problems, there's not really much difference between what was reported in those people who were taking placebo or pitavastatin. Think about this for just a minute. Somebody could come in complaining of achy muscles. Well, they may have run a marathon and their muscles may be sore from that. We still have to report that. So if they were taking placebo, that would still count as muscle aches, even though it was from their running a marathon. So now when we look at diagnosis of diabetes, there was a little bit of a difference here, and this difference was significant. So not as many people in the placebo group got diabetes. More people got it in the pitavastatin group. Again, small numbers overall, not very many people, but still there was a little bit of a difference. And this has been seen before in other studies of statins. And there were more people that developed muscle aches and muscle problems with pitavastatin than those people with placebo. But the good news is that all of these problems did not result in people having to stop the study. So I think it's important to recognize that overall, we think that the safety of this statin is very much like all the other statin trials we've seen, and it seems pretty safe in people with HIV. So when we think about people with HIV who are at low to moderate risk for heart disease, the group we chose to study here, we thought that pitavastatin really made a difference. It lowered the adverse cardiovascular events on average by about 35% and made a difference in the lives of those people. So our conclusions were that there's really been no other study that was done previously that looked at these heart events in people with HIV, that typically we wouldn't always be recommending that they take a statin medicine. So amongst people who have HIV, who are between the ages of 40 and 75, who are taking HIV medicine and are at low to moderate risk of heart disease, pitavastatin is effective and prevents cardiovascular events or heart attacks and strokes. And we should consider this and consider that treatment and prevention may need to change because of the results of this study, knowing that we want to prevent people from having heart attacks and strokes. So, what are the next steps? What should be happening next? What should we consider? So I think the question that will logically come up to people is, should I be on a statin? You know, is that the right medication for me? And that's a really good question. So we have shown now that in REPRIEVE, statins help to prevent heart disease. So it's a good idea to talk to your clinician, your healthcare provider, and say, what's my risk? Do I have a family history risk? Am I in the right age category? Do I smoke? And so is a statin right for me to prevent problems? I think that's really important to have those conversations. And when you think about it, you have to think about the risk benefit. Like, what's the chance something bad is going to happen to me if I take this statin versus what about getting benefit? And I think you can ask a lot of questions. Do I have other risks for heart disease problems? Am I worried about taking another pill every day for the rest of my life? Am I concerned about the side effects? So you have to think about your own personal circumstances, your values and life choices. And remember that it's not an easy question and that you can talk about it, think about it, do your research, and then make a decision about whether statin is right for you or not. So which statin is right for me? I think that's an important question. We studied what is called pitavastatin, and that is available in the United States, but it's available right now what we call under patent as a drug that's marketed by the company Kowa as Livalo, but it may not be available to everyone unless you have a specific kind of health insurance that's willing to cover it. And in some countries, it may not always be available because it's not available in every single country. Now, we looked at this medication because we knew it was very safe. It didn't interact with a lot of the HIV treatments that people were using in 2015, and it really lowered cholesterol very well. So if it's not available to you personally or in your country or circumstances, there are other statins that probably will work just as well. So that's something to consider. So there's a number of them that are available in different countries, and I've given you a list of different ones. They come under different names as well in different countries. But here's the list, and many of these may also be equally helpful and beneficial to people if you can't get pitavastatin. So things to know about statins, as I mentioned, people who have diabetes are always recommended to take a statin because it does lower the risk of heart attacks and strokes. So if you decide to take a statin, you should have your blood sugar levels checked and monitored because a small percentage of people can develop diabetes while taking a statin. But the other serious problems like muscle damage or liver damage were just really not seen in our study. So it's very reassuring that in general, statins were pretty safe in this trial. So it's all about shared decision-making in my mind. You should have a conversation. I had 2 or 3 of these conversations actually this morning with some of my patients. And we agreed that we would just talk about it in the future, that I don't necessarily just immediately always write them a prescription, that they could think about it. So you have to talk about it and consider, is this the right decision for you? Don't forget, a healthy lifestyle is very, very important, okay? So even just doing exercise, 120 minutes of some kind of activity like walking, jogging, swimming, biking, running is very, very important. And eating healthy, a little less of the McDonald's and fast food and a little bit more of the salads and vegetables and healthier things. This is important, and we've looked at people's healthy behaviors in the REPRIEVE study, and we could all probably do a little better. So to reduce your own risk, don't forget, if you smoke, you should quit smoking and eat that healthy diet with fruits, fish, and foods that are lower in saturated fats and carbohydrates. Be a little bit more active. If you're watching TV, maybe you do a little bit of exercise or something while you're watching, and try to keep your weight in a healthy range. These are all important things to do. If you're interested in the full results of our study, it's available on our website, and you can certainly look at it, and our publications are there. We try to make this accessible and understandable for people with or without a strong science background. So I wanted to thank everyone for joining and thank Katie and Marissa for helping organize this. And I'm going to stop the formal presentation, and we will look into the chat and see what questions there are. And maybe just to make life a little bit easier, Katie and Marissa will tell me if there are questions in the chat, but I'll try to look. And I don't know, can people raise their hand and ask a question as well? Is that possible too?
That's also possible.
Okay, so I'll let you guys moderate this part.
Okay. Jules Levin.
Hi, can you hear me?
Yep.
Hi, Carl. Hi, everybody.
Hi, Jules.
Thanks for the great study. Fantastic data. And it's kind of amazing that so many people are now talking about statins. As a result of your study, people with HIV that never really talked about it before, they acted like they never heard of a statin before until after this study. So you certainly publicized the possibility, the potential benefits. But I want to raise a safety issue. If you look in the New England Journal of Medicine in the supplement, and you look at table 8, table S8, you look at grade 2 myalgias and muscular weakness in pitavastatin versus placebo, it's higher for myalgia than placebo, 37 versus 8. So I'm just wondering if you could comment on that. That's grade 2. And grade 3 was 34 versus 22.
Yeah. So, of course, by the way, just for those who are not familiar, when we grade things, what we're really doing is how serious is a problem. So if your muscles hurt you a little bit, but you don't yet have to take any medicine and it wasn't anything that really interfered with your life, we might call that a grade 1. If you had to take a little bit of Tylenol or something, we call it a grade 2. If it interfered, you couldn't go to work, you couldn't go to school or something like that, it's grade 3. If it wound up you were in the hospital or something was pretty serious or something more significant happened, it's a higher grade. So I think, Jules, you're absolutely right that there's always a difference between statins and placebo. And we know that statins do this. I think the good news about these general myalgias and muscle weakness is the numbers were very small. We had 7,769 people, and we're talking about less than 100 people who are experiencing these problems of muscle aches. And also that whenever you stop the statin, most of the time those muscle aches promptly go away. And so it's not something that's lasting for people. It's not something permanent. And if you look really closely at our data, one of the things that may not be appreciated is most of those differences occurred in the very first year. After the first year, there really was no difference between our two groups in terms of people getting muscle aches. So the take-home message that I have is if you decide to use a statin and you don't have any muscle problems for the first year, you're probably out of the clear and in good shape, and that's probably not going to be a problem. But if you are taking a statin and you develop some kind of muscle ache or muscle problem, I think the best thing is talk to your healthcare provider and say, could this be my statin? Should we hold it for a little while? Should we figure out if this is the problem? The last point, Jules, I'll make is that the really serious side effect when muscles actually die, something called rhabdomyolysis, we did not see any difference at all between the groups. And there were only a few cases that were equally split, both between placebo and the pitavastatin group.
So could I ask you a follow-up on that?
Sure.
Did you happen to look to see if the cases that you did see with what I'm talking about, if there was more in people with a history of hepatitis C or hepatitis B?
We have not looked at that yet, but it's an excellent point, and thank you for bringing it up, and we'll be sure to look at that because I'm sure that we're going to look very carefully at people who had side effects and try to see if there are any factors that might be predictive. That's a very good point.
Now, one more thing. Could you talk just for a moment about the potential, the prospect for statin actually being an anti-aging drug, considering the improvement in, inflammation markers in the study and its effect maybe on other comorbidities and aging in particular?
Yeah, I think it's a great point. So first of all, I think people who have been living with HIV and are aging are experiencing a number of different problems. This is really important, very important in our community and important in the world. And we really need to find better ways for people to age as gracefully as possible. We're all going to get older, we hope. But what we want is that we get older at the right time and not with so many problems. So I do think that statins may play a role. And we're certainly hoping to look at this a little bit more over the coming months and years as we do further analysis to see if we look at markers of aging, which we will be able to look at, do they change? And are there differences between the group? And might this be a little bit of a clue that maybe there's a further benefit for that? I don't think that any of us think that statins are a fountain of youth and that this is going to make, all the difference in the world. We'll probably need to find other ways to address this inflammation, or what we tend to call inflammaging in people. But I think it's a really important question, and we hope to contribute more evidence in the coming months and years, Jules, to this question. And maybe even we'll get lucky enough to follow people even further out to see what really happens with aging.
Okay.
Thank you. And let me answer a couple of other questions before we get to the end too. So
I have one for you. Can I ask you one that was from the chat?
Yeah, sure.
Okay.
Is it about unblinding?
We can do that one. There was another one.
Okay.
So this is someone who said, if people with HIV are aware of inflammation in an area such as the gut, can it be assumed or not that they may be experiencing it elsewhere? And should they be concerned about cardiovascular issues and concentrate also on ASCVD and LDL?
Oh, yeah. So that's a great question. So inflammation happens all over our bodies. It happens in the brain. It happens in blood vessels. It happens in our tissues, in our muscles, in our blood vessels, and our major organs. So really, it's not just the gut where there's inflammation. It is in many places, because all of the cells that are responsible for our immune system and inflammation, they travel all over the body. They have functions all over the body. And when they travel, many of the signals that they put out that create the conditions of inflammation can occur in many places. So yes, I think people need to be worried about heart disease and other problems when you have HIV, because HIV is not confined to one spot in your body. So I think it's really important to think about it more globally all over your body. Someone did ask about unblinding. We are going to unblind the study participants, and that will be done in the coming months. We are waiting to finalize our data set and clean up all the information before we unblind, because we want to be sure that all the information we have till the end of the study, when the last participant was seen at the end of July, that all of that information is accurate, correct, and unbiased. And then we will be able to unblind people and let them know, did you get pitavastatin or did you get placebo? That information will be shared with their local study team, wherever a participant enrolled, and the local study team will be responsible for telling people this is what you got. We have actually drafted some letters and information that we will send to the sites to explain this process so that they can get that approved by their institutional review boards that reviews everything we do in studies to make sure we do it the correct way. And we will send that probably in the late fall, early winter to the sites. But before the end of the year, I expect that most participants will know. But I want you to be assured that decisions for people who are on the study about whether or not you should be on a statin, you can make those decisions whether you are on a placebo or you are on pitavastatin. It really doesn't matter, because that decision about what you do in the future should be about whether or not you think that with your healthcare provider that it's the right thing for you to really decrease the risk of heart disease going forward. All right.
All right, thank you. We have a question from Janice.
Yes, hi. Very good. I enjoyed this. Since I am on the REPRIEVE cab, I'm also a representative from Rutgers, New Jersey Medical School, New Jersey. You answered the question. That was my question, but I wasn't sure that I put it in the right place. So you're saying that, because people have been asking me, so I wanted to make sure I had the right answer. So you're saying in late fall or early winter, they will know?
Yeah, I think they will know. And if, for example, you had somebody who is at Rutgers, then the investigator there at Rutgers and their team will reach out and say, hey, here's what you were taking, and they will tell you. So I expect a lot of that to happen, most likely, just before the holidays for most people.
Okay, great. Thank you so much. It was a great presentation. Thank you.
Yeah. I see another question in the chat about why we used pitavastatin. And the real reason was because pitavastatin is pretty easy to use with a variety of different HIV medications. So if you think back in 2015, and we look back to our study participants, about a third of them were taking what we call protease inhibitors, and another third of them were taking what we call non-nucleoside reverse transcriptase inhibitors. These are two big categories of HIV medications, and they have a lot of interactions with the statins. Sometimes they lower the benefits of the statin. Sometimes they increase the amount of the statin. Sometimes it's even more complicated than that. We wanted to choose a statin that really wouldn't be affected by those medications very much, and pitavastatin just happened to be that one. And so we were able to get that for our particular study. This way, we didn't have to adjust the dose based upon what some other medication that someone was taking. That makes it really, really hard to do a big study when you have to adjust the dose based upon other medicines people are taking. So that's why we chose pitavastatin. And there were other studies going on at the time that have since been published with that particular medication in people with HIV. So, other questions?
I think, Tim, did you have a
Yeah.
question?
Yeah, hi, Katie. Thank you so much. Doctor, thank you so much. This was a really, I echo what was said before. This was a fantastic presentation. My question is about the diabetes, the folks in the study who developed issues with their blood glucose. Were there any patterns? Were these folks who already were at risk for diabetes, or were these more spontaneous occurrences?
Well, I've been struggling with this quite a bit. So, and Dr. Stephen Grinspoon and I have been discussing this extensively, and we do have plans to look at this carefully. The bottom line is we don't really understand why statins are associated with a higher chance of someone getting diabetes in any of the studies that have been done. And when we looked carefully, the risk that we saw in our study was no different than the risk in other major statin studies that have been published. One's called the Jupiter trial, which was done with rosuvastatin. Some people know that as Crestor. So, you know, we are going to look carefully at the characteristics of people. You know, are there any clues for those who might be more likely or less likely to develop diabetes? You know, is there something about their particular metabolism that makes a difference? One thing that we did look at, which was very, I think, instructive, was the CDC collects information about people of all ages who develop diabetes. And as it turns out that the number of people who develop diabetes fits within the range of what the CDC collects for all people living in the United States who develop diabetes in the age group of 40 to 75 years. So the number of people who got diabetes is not that different of what we're seeing in the United States. And as you know, in the United States, we're seeing an explosion of diabetes and metabolic problems. So I can't answer your question yet, but we're very interested and we very much intend to look at this very carefully so that we can provide further information to people because we think it's very important. Now, I do think, as an aside, I've thought a lot about this. Well, what's worse, getting diabetes or having a heart attack or stroke? I think everybody has to make that own personal choice. For me, I made that choice because I am taking a statin. And so I decided that I would rather struggle with diabetes than I would if I have a heart attack or stroke, because I think that the chance or the risk to me is more acceptable for that. So I think everybody has to think of this in many different ways, but you raise a really good point, and we are going to look at this some more and definitely try to provide more information about who's getting diabetes and why.
Thank
Other
you.
questions?
Two more questions from the chat. So can someone living with HIV who already has cardiovascular problems use statin to reduce chances of stroke or heart attack?
Yes, and that's absolutely important. So we know from many, many studies that if you've already had a stroke or a heart attack or a heart problem, you need a statin. That really is considered standard of care. And it's something you should talk to your healthcare provider about because it's important to reduce the chance of it happening again. I know we're running short of time, so I'm going to keep my answer shorter.
The last one there. So is the stimulus or inflammation or other events a tipping point for us to consider statin as part of kind of the care package for people living with HIV, especially aging populations who are at risk?
Yeah, so when we looked at this, we did this really cool analysis. So we looked at how much of the benefit were we seeing from pitavastatin was because we lowered the LDL cholesterol, because that's what statins are designed to do. They interfere with a specific protein that leads to the production of cholesterol. They block it. So we know that's a major effect. And when we looked at predicting that, it predicted about half the effect. The other half of the effect, that gap, is what we're wondering might be that inflammation or immune activation, that statins lowered that in people. And so one of the things we did was we designed a study within a study. It's called a sub-study. And in this mechanistic sub-study, we are looking at inflammation. And I can't present any information to you yet publicly, but I will tell you soon that we will be presenting information about inflammation and what happens when you use a statin. But we really think there are what we call off-target benefits from the statin, and it's most likely related to lowering inflammation and immune activation.
Great. Well, this is incredible timing because there are no more questions that I see, but feel free. Again, we might have time for one more. I do want to thank you, Dr. Fichtenbaum. That was an incredible presentation, really informative. And also thank you everyone who joined today. We have members of the REPRIEVE CAB here. We wanted to thank you all so much for helping us to develop this slide presentation, as well as former REPRIEVE participants and anyone else who joined. We really appreciate it. It was incredible attendance. These slides and the recording of this presentation will be posted on our website under the reprievetrial.org for participants page. We hope to post that in the next few days, so please go ahead. We do have a future presentation on September 29th in Spanish. Dr. Carlos Malvestuto will be presenting that day. So if you know anyone who would want to join that presentation, please make them aware. Looks like we do have one more question. Do we have time for one more?
Yeah, I think there was a question about guidelines, and we are certainly expecting guidelines to be changed in the coming year or so because of this study. So stay tuned.
Person with their hand raised, and if they have a question, okay, looks like they are away. All right. Thank you, everybody. Take care.
Thank you, everybody. Have a great day.
Thank you.